Good evening, everyone, and we would like to just take a moment and welcome you to the HealthyStart overview of the treatment that was devised over the last 50 years. And once you know this, well, you can't unknow it. My name is Kathie Turner, and I work in communications for Orthodontist's HealthyStart. And I think that we have somewhere around 130 doctors that have registered to learn more tonight about this program. And it's the full range of the medical and the dental world. And really, that's what's required, because the patients are coming into all of your offices. In the last couple of weeks, we've been to a number of shows. In the last week, in fact, in Boston, 2 of them all related to sleep. So on our program tonight, we know that we are being viewed by pediatricians, by pediatric sleep specialists, by orthodontists, by dentists, by ENTs. You're all welcome, and you're all very much a part of the discussion. And at the very end, we'll try and field a couple of those questions. We have very good doctors that work for us and with us as lecturers and trainers. And with us tonight, on top of the person that's going to carry the heavy load and do the big presentation, we also have Dr. Jill Ombrello, a central dentist in the Dallas area, and Dr. Amanda Wilson, orthodontist, who's a consultant into the world of orthodontics and dentistry. So I'm going to encourage you to listen in, make notes, and at the very end, we are going to share with you a very special, well, reward or appreciation. We have a very big event coming up. We want you to be a part of it, and we think that you will be intrigued to do that. So let me get started out here by telling you a little bit about our company, the background, and the person behind it. This is Dr. Earl Bergerson, board certified orthodontist. He is DDS, MSD, ABO, and he has created so much in his lifetime. In fact, 50 years, and that's a little hint of what's coming. Later this summer, we are going to be celebrating his contribution to the world of health and actually changing the world. That celebration is going to be in a lecture in Chicago. He also taught as an associate professor for 25 years at Northwestern Dental School before they closed that down. Well, now Northwestern Law School will be the home of the lecture coming up where he's going to be celebrated. He started Orthotain and HealthyStart. He's devised the appliances that you're seeing him hold. He works with the airway, and in all his years, he has found that there are probably 3 things to have a major impact in the field. One of them was fluoride, the next one was implants, and the third one is oral habits, the airway, the impact that it's having. He is the most prolific developer of patents in the U.S. since Thomas Edison, from what we're told by the patent attorney. He has 80 monographs. He's been published more than 80 times. He has developed a full series and line of removable appliances that are FDA approved, Health Canada certified, the equivalent of a Class 2 medical device. I think that you're going to find him to be a genius and a world changer, and he is the man behind everything that we would consider the biggest thing to hit your profession. Who are you going to learn more about this from? Dr. Anthony Marino. He is an orthodontist out in California. The wonderful part about Anthony is that you're going to hear not just from his education, but his experience and his wisdom, because he has been using this treatment system for 30 years. You see that he went to dental school at Ohio State and also did residency and his MS degree, his orthodontics residency at OSU. That's where he was initially introduced to all of this. He's an orthodontist in private practice now in Vacaville and Fairfield, California. But what he's going to bring to the discussion tonight, I think, is going to create a very big picture for you. And without further ado, I am going to hand it over to Dr. Marino now so that he can share, as you see him with Dr. Bergerson, some of Dr. Bergerson's cases and some of his own. So we are enthralled. Everybody stay with us to the very end. We're going to get your questions answered. We're going to get the gift to you. And Dr. Anthony Marino, go ahead, take over and share your screen.
Good evening, everybody. So glad that you can all come and listen. This is really a wonderful opportunity to speak to both the medical and the dental profession simultaneously. And hopefully that this will be of interest to everyone on the call. Okay, we're going to talk about the silent crisis among America's children, sleep disordered breathing. These are some of the symptoms that we want to look at. There's estimated 9 out of 10 kids suffer from 1 or more of these symptoms, and I'll list them. I'll read them off: ADD, ADHD, bedwetting, difficulty in school, especially math, science, and spelling, mouth breathing and snoring. This is what we hear of quite a lot in my office. Restless sleep, delayed or stunted growth, nightmares, irritability and anger, morning headaches. We're hearing more about this with children as well. Chronic allergies, eczema, asthma, depression. Now, can you imagine a kid having depression? It's real. Tooth grinding, we hear this quite frequently as an orthodontist. Swollen adenoids and tonsils, aggressive behavior, daytime drowsiness, peer problems, few friends, frequently wakes up at night, and sleep talking and walking. Now, the reason this list is fairly extensive is because we're starting to ask questions and getting some amazing answers from these parents with these children. Okay, we weren't asking all these questions before, we are now, and the verdict's out. We really have to address this. Okay, so what options do parents have to help their children with outward symptoms? We know that there's drugs, stimulant drugs, amphetamines, Benzedrine, Dexedrine, Ritalin. There's other prescription drugs as well. There's psychiatric testing, counseling, therapy, surgery, TNAs, tonsils and adenoidectomies, sleep studies with sleep medicine docs, that hopefully we have a few on board listening in, allergy testing, a special education and tutoring, sleep aids, diet changes, rapid palatal expanders. If you are not familiar with the rapid palatal expander, this is what it looks like. Let me see if I could find the screen. That's a rapid palatal expander. It goes in the upper jaw. Okay. What do these conventional treatments have in common? They address symptoms only and not the root cause. They tend to be short-term Band-Aids, often involve several drugs and many side effects. They can be costly, painful, time-consuming. So in short, I just showed you a picture of an RP, and this is where I could stand from. This is my world. We can put an expansion appliance in a person's upper jaw and expand the arch, which is great. It really does help temporarily. It doesn't solve all the problem, but it does help temporarily. No question about it. Tonsils and adenoids, having those removed, no question, it does help. If a child's snoring or has sleep disruptive breathing and they have enlarged tonsils and adenoids, wonderful thing to do, but the habit pattern of mouth breathing still persists. We still have not addressed those issues. Okay, research over the past 20 years has linked each of these symptoms to a root cause. Now, this research is medical research primarily, Cleveland Clinic, Stanford, NIH. I've looked at these already. I was amazed that these things have been in publication for 20 years. And what they're looking at is mouth breathing, narrow palate, improper tongue placement, and jaw relationships as the root cause. Dental professionals have the knowledge and tools to impact the development of a child's airway to increase the oxygen intake and reduce carbon dioxide buildup. So here's the deal, okay? This is a medical problem that can be helped significantly by the dental professional community. All right, now it's more about it's much more than cavities and straight teeth. It's about the overall future health and well-being of every child. So the drill and fill days are great, fine, wonderful, but they're over. There's other things that we have to look at, and these are really important to consider. We have to learn today we're going to learn to identify sleep disordered breathing symptoms, evaluate these symptoms, understand and identify the root cause, diagnose the problem, and treat. Okay, these are pictures of children that we see in both the medical and dental communities in our offices daily. Would you consider these children looking healthy? Look at the circles under their eyes. Notice the boy on the right side. You can see him with his lip apart and his teeth are kind of showing, protruding. And of course, the little girl on the left has circles under her eyes. Look at the profiles of these children. Are these considered healthy children? The one on the left, you can see her upper front teeth kind of hanging over the lip. The lower lip is curled under those front teeth, so she has a retrusive mandible. And the child on the right, you know, she has more of a funnel look. Are they considered healthy? Okay, the root causes. Mouth breathing, allowing the mandible and tongue to displace posteriorly in a reduced airway and air exchange to lungs. Habits like finger sucking and abnormal tongue posture and swallowing. Upper arch constriction, of course, is a big one, and a high palate decreasing the nasal breathing. The root causes are reducing REM sleep, affecting brain function, endocrine, and immune situations too. We've all seen graphs like this of normal craniofacial growth and development. This is one that's depicting children from ages 2 to 17. And on the bottom, you can see that they give both the male and female percentages as far as the age goes. At age 2, 68% of the male craniofacial growth is completed, 73 of the female is completed, and it goes on to 17 years of age. All this growth and development is taking place pretty early in the game here, and so much can be done early. Okay, and please pay attention to the fact that that growth and development is a downward and forward growth and development on the craniofacial skeleton that we just saw. So why are so many of these children not experiencing normal growth as well as social and personality development? Well, there's many reasons, and this is a theory, and it's been proven. There's other things that are to be considered, but if we look at the fact that the child's using a pacifier maybe longer than 6 months, prolonged nipple bottle use beyond 6 to 8 months, lack of breastfeeding, a soft diet, you have foods for the babies, first teeth meet first snack, and that first snack is called graduate's puffs, the nutritious snack that melts in your mouth, okay? All right, result of pacifier and prolonged nipple bottle use and resulting finger sucking. This is what you would see. The child's teeth would touch in the back, but there'd be an opening in the front. That opening is the area where the finger goes, or the thumb, or the pacifier, or the binky. And what happens is when that child wants to swallow, they have to push that tongue forward against that hole, and the tongue becomes the obturator so that the fluid can go to the back of the throat and down the throat, okay? This is obviously a common picture that we've all seen of airway, and we're looking at the nasopharynx, the oropharynx, and the laryngopharynx, and the colored areas. And then the nose, here we want to know about the nose and the 5 functions that the nose serves as an air passageway. It warms and moistens inhaled air. The cilia and mucous membranes trap dust, pollen, bacteria, and other foreign matter, contains olfactory receptors which sort out odors, and aids in the phonation and the quality of the voice. And of course, we've all seen children that are cleft lip palate, and we know that they have a nasal quality to their speech because of the cleft or cleft repair that they've had. Improper air exchange. The most common problem for improper air exchange to and from the lung, the oropharyngeal constriction, probably due to nighttime mouth breathing, is present in about 43% of a sample of 500 in a study done by Stevens and Bergerson in 2016. Mouth breathing while sleeping causes airway constriction. Okay, so I'm going to play this little clip here and watch what happens here with this little boy.
Listen to this mother describe her baby's sleep disorder breathing. There you go. Now watch what happens when she's able to open the airway by simply shifting the position of his jaw. Now watch what happens when I take his jaw and I just bring it forward. If I can, see if I can. I open his airway. Just bring his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose.
So let's see what happened to the airway. Okay, now this is 2 pictures of 5-year-old kids, and we're looking at the airway where the arrows are. The restricted airways on your left side, and the normal airways on your right side. Now, watch what happens when a child opens their mouth just a little bit, maybe about a ½ inch. The oropharynx is closed up significantly. An average 5-year-old would maybe have that width that you see where those arrows are, maybe about 7 millimeters. Watch what happens when they open their mouth about a ½ inch or so, and that is restricted significantly. So now if a child's laying on their back with this going on with their mouth open and the tongue is laying back there and obstructing the airway, or the lower jaw is laying open, that child's breathing with maybe a millimeter of space and trying to breathe throughout the night. Now the child will, but it's what we call disruptive breathing, sleep disordered breathing. Now, the child's doing this day in and day out. We all know what happens with adults that have, they develop this thing called sleep apnea. They go to the sleep medicine specialist, they get a CPAP machine, or they get an oral device so that they can draw their jaw forward and close their mouth together, and they can breathe better through their nose. What does a child have? Okay, this is what we see with these children. Parents are coming in and asking about this, and many times when a child is snoring or grinding their teeth, and the parent is concerned about this, many times they will come to the office of the pediatrician, the orthodontist, or whoever, and they'll say, well, maybe the child will grow out of this. Okay, well, what happens in the meantime? Okay, the child's going to have a lot of other problems that they have to contend with and deal with in school, with behavioral issues. Maybe they're getting up in the morning and they're crabby, or they manifest ADD, ADHD symptoms. And that is all because they're not sleeping properly. They're not getting the proper oxygen content that their brain needs throughout the night. Okay, so the question here in this little slide is kind of cool because it says, what does your child's airway look like? Does it look like a garden hose, or does it look like a little coffee straw? Something to consider. Okay, this is the sequence of events that occurs. Mouth breathing and snoring causes a compromised airway, which causes sleep disordered breathing. And of course, the mouth breathing and snoring, we talked about the extensive bottle feeding and pacifier use, processed foods, poor oral habits with thumb, finger, lip sucking, and tongue thrusting. Compromised airway, reduced airway and restricts airflow, reduces oxygen and increases CO2, affects brain function, immune and endocrine systems, causes swollen adenoids and tonsils, a low tongue posture and position, and tongue thrust, underdeveloped dental arches, overjet, and open bite and cross bite. Along with this, I want to present to you that sometimes you have a frenum problem under the tongue, and we see this with little children, particularly if they have prognathic mandibles, they're tongue-tied. And so that frenum under the tongue needs to be released, and now we have these wonderful laser procedures that are available, and that's a really easy thing to do with these children that don't have proper tongue function, and they lay that tongue in a low posture. Okay, and then of course this compromised airway goes to sleep disordered breathing, and we've already discussed some of the symptoms that we see. Okay, so now we're going to give you the introduction to HealthyStart. HealthyStart addresses the root cause. It expands the dental arches, a habit corrector, and I'm going to show you one of these things. All right, if I can. This is what a habit corrector looks like. We'll take another little closer look at it. This is a very soft, pliable appliance. This one has a little tether on it that the child would put in their mouth very comfortably and nicely. There's certain little parts to this thing that establishes proper tongue position, proper jaw position, and proper size when the child wears this at night and maybe an hour during the day. Okay, so expanding the dental arches with a habit corrector would be ideal and perfect. It's non-invasive. The materials that are used are all FDA approved, like what I believe was used, the term was a class 2 medical device. There are expanders of different types. These are different types of appliance that a child would use. A little bit more invasive and perhaps harder to wear during the day and talk with these appliances. And then of course the RPE that we talked about earlier, and that was this appliance here, the expander that fits in the roof of the mouth and is actually that little, there's a little jack screw in the center of it that is turned, we usually recommend they turn it twice a day, which is a 1/4 millimeter each turn twice a day to establish a greater width of the maxilla. And typically we'll see changes with that type of appliance very, very quickly. However, it's not long lasting because we still have the other symptoms of perhaps not breathing with their lips together and breathing through their nose. It's much more difficult for the tongue to go over the roof of the mouth with an appliance like that in their mouth. The next is establishing nasal breathing. These HealthyStart systems discourage and eliminate mouth breathing. It increases oxygen intake and ensures REM sleep. Nasal breathing prepares the air for optimal assimilation by the lungs. And we're training the tongue. Now, with these appliances, all of them are designed specifically, okay, to train the tongue to go in the proper orientation in the mouth. So when you're training the tongue, it strengthens it and conditions the tongue. It repositions the tongue upward in the palate. It promotes proper swallowing and speech. And the RPE, the expander, it prevents proper tongue position, of course, because the expander's in the way in the roof of the mouth. And it affects your swallowing habits as well. So in order for the hardware of a rapid paddle expander to work, it has some bad habits that can be established with tongue posture and position. The HealthyStart system eliminates bad habits. It eliminates thumb sucking, tongue thrusting, reverse swallow, and eliminates open bites. And by the way, when you hear the term reverse swallow, typically when you see children like this, you'll usually see a unilateral posterior crossbite. It's a term that most Europeans use, and maybe we don't hear about it as much here in the States. Okay, the HealthyStart system also advances the mandible to correct the overjet. So if you're bringing the mandible forward and the child is using this appliance properly, which is easy to do because it's designed so that the tongue is postured properly, the jaws are properly postured, and then it's just a matter of the child to grow into the corrected position. It prevents posterior slippage of the mandible and tongue during sleep. It increases the airway and can correct most of the symptoms caused by sleep deprivation. These appliances encourage proper facial and body growth since lack of REM sleep impairs function. It corrects most orthodontic problems. It develops an ideal overbite and overjet. Now let's see if I can give you something like that to look at. Okay. Let's see if I can do this here. This is just sets of molds, and you can see how the teeth look and how they interdigitate. The top teeth cover the lower teeth just a little bit. Okay? Some of these children, you'll see them, they usually look something like this. And I'm exaggerating a bit, but we do see them like that. Okay? Or they would be, this would be a prognathic type jaw. All right, so we won't, so you get the idea. This is the ideal position. This is what these appliances will do every single time these appliances are worn. It provides the proper intercuspation of the dentition. The molar relations are to a class 1, what in dentistry we would call a class 1 class 1 occlusion, where the top and bottom jaws are in proper orientation as well as the teeth. And all 28 teeth, not including the wisdom teeth, are in proper place by the age of 12. This also provides proper fiber development on straight teeth for stability. And what this means is basically as these teeth grow into the mouth, okay, usually we see a child that has all primary teeth and maybe 1 or 2 adult teeth that are just coming in, and we can see that there's an issue going on. When those adult teeth start to erupt into the mouth, they have periodontal fiber bundles that surround those teeth and connect to the bone. Well, what happens is if those teeth come in crooked, those periodontal fiber bundles attach to crooked teeth, and they're like little rubber bands. So then orthodontics takes place several years later. We move those teeth, we get them straight, but those periodontal fiber bundles have memory, and they are accustomed to being in a different position, a malposition. So if a retainer is not worn long-term, those teeth will relapse. And that's what's happened to many of us, and we all know about relapse from orthodontic treatment. This appliance reduces and eliminates future relapse due to the proper alignment before the adult collagenous periodontal fiber bundles form. And it reduces the chance for orthodontic treatment later. These are all pluses, every one of them. Okay, the incidence of sleep disordered breathing symptoms in children from 2 to 19 years of age. This was a study done by Stevens and Bergerson, and the incidence of sleep disordered breathing symptoms in children from 2 to 19 was published in the JAOS in the winter 2016 issue. This was a great questionnaire. I hand this out to all my patients' parents when they come in for an initial exam. The study consisted of 501 cases ages 2 to 19 years of age and addresses SDB through a parent questionnaire containing 27 items. Most of what we've looked at. This form can be downloaded from the HealthyStart.com system or the HealthyStart.com website, and you can actually pull this off the website and use it in your office tomorrow. This is given to the parent, and the parent would basically give a score of these 27 items about their child when the parent is observing the child at night, as far as snoring, mouth breathing, allergy symptoms, excessive sweating while asleep, bedwetting, teeth grinding, frequent throat infections, and there's several more there. And these are only 27. There's obviously many more, but these are the primary ones that we're looking at. The results: mouth breathing and snoring are commonly associated with more SDV symptoms than any other symptoms studied. 9 out of 10 children had 1 or more symptoms of SDV. 60% of the sample had 4 or more symptoms. 1 out of 5 children experienced bedwetting. Between ages 4 and 12 years of age, 92.6% of the symptoms did not self-correct, while 30% worsened with age. So that wonderful thing that I've heard and have used years and years ago, where maybe it'll get better, maybe that snoring and grinding will get better, I think we have a better solution now. Sleep deprivation, percentage of incidents. Let's just go over the ones that are highlighted here. Mouth breathing nights, 43%. If they snore at all, 37%. Talks in their sleep, 31%. Wakes up at night, 29%. Restless sleep. These are kids that are all over the bed. 26%, 27% actually. They mouth breathe during the day. We see these children every day in our offices. They walk in, we see them with their lips apart, 25%. ADHD symptoms, 25.2%. Let me move this thing over here. Okay, they snore 1 night a week, 24%. That's not a highlighted one, is it? Okay, they fall asleep watching TV, 13%. Difficult labored breathing, 12%. How many times do we see children or heard about children going to the movies and they fall asleep during a movie and they snore very badly? I just heard of one today. It just happened to be a parent of a grandparent of a child that I treated many years ago. And I was asking her about these issues because I wasn't asking those questions 20 years ago. And she said he snored so badly that if he goes to a movie, he'd fall asleep and start snoring. Would be rather embarrassing. These are real. It happens. Okay, the average number of symptoms present in children who mouth breathe were 8 symptoms. If a child does not mouth breathe or snore, the average number of symptoms present is 2. And this is quite a list here. If they snore at all, difficulty listening. Now, let me see if I can get this part off of my screen here so I can read it. Talks while they sleep, allergic symptoms, fidgets with hands, restless sleep, teeth grinding, feel sleepy and irritable during the day. This was a fabulous study to give percentages of these symptoms that we found in children with mouth breathing during the day and night. Implications of the study. The findings show that SDV is much more common and affects children even as young as 2 years of age. And I have experienced this myself, where parents have come to me and they have looked and they seeked out professional medical care for their children that had issues with snoring and issues with grinding their teeth. The child's tonsils and adenoids were not enlarged, but the child had these symptoms since they were 2 or 3 years of age. They get to me about age 9. They already have some adult teeth in their mouth. They have very, very constricted arches. And lo and behold, we have to use all this hardware in their mouth to get things corrected. Fortunately, we have something to use as far as orthodontic concerned, but we can do this so much more nicely and easily and much more comfortably with the HealthyStart system using these removable appliances. And it makes a note here to begin treatment as early as possible to ensure permanent changes. Parents need to know that there is help available, and of course the medical and the dental profession needs to know that there is help that the HealthyStart system supplies. And it's been a marvelous journey that I've been on using this technology for over 30 years to see these type of changes occur with children in a relatively short period of time once they get started with this. And typically when you're wearing these little appliances, these children are wearing these little appliances, I tell them this is kind of like a little pillow. You know, it's nice to snuggle into a pillow at night. And usually when they put this little appliance in their mouth, it's like a little pillow. It's a little comfort thing that they can wear throughout the night and a little bit during the day. And lo and behold, I mean, parents come back and they're telling me literally within a few weeks, they're following appointment that a lot of these symptoms are going away or have gone away. Okay. It's important that we identify the outward symptoms displayed in 90% of the children that enter our practices and can significantly reduce the epidemic and enable us to successfully treat the overall health of our patients. Okay, this was a really nice study. This was by Drummond, Stricker, Wong, and Buxton in 2002, and this shows an MRI of the brain, and it shows what happens when someone doesn't sleep real good for one night. The reduced oxygen increases sleep deprivation and eliminates or greatly reduces REM sleep. REM sleep required for proper brain function is on that top series of three pictures there, and you can see the colored areas of the brain. Okay, and then the MRI of the normal brain function is what you're looking at. On the one below is the brain function with one night of sleep deprivation. Just one night. Quite significant. The detrimental effects of the brain and endocrine and immune system are also considerations. Less REM sleep interferes with removal of intercellular brain toxins. Beta amyloid reduces learning, judgment, reaction time, memory, and attention problems, dishonesty, and may be linked to dementia and Alzheimer's disease. And this comes from a study in Rochester, University of Rochester Medical Center in 2013. Plaque found between the brain cells in dementia and Alzheimer's disease, beta amyloids, it's the same toxin found in those lacking REM sleep. Kind of interesting. 3 consecutive nights of 4 to 5 hours of sleep can cause irreversible brain cell damage. University of Pennsylvania, 2012. Antibody levels increased 56% for each additional hour of sleep. Beth Israel Hospital in Harvard, 2003. These are pretty significant studies to consider. Now, I'm an orthodontist. Most of you medical people that are listening to this probably understand a whole lot more about this than I do. All I can say is that these are very significant issues that we need to deal with children now when they're young, and not let this thing kind of smolder and damage their health as they age and grow. One night of incomplete sleep can affect endocrine and immune system. This is from medical school in Israel Medical Center. Insulin reduction, 40% after 4 hours of sleep for 5 nights, University of Chicago. Appetite stimulant hormone is also affected, increased 28%, same sleep pattern. Leptin inhibits hunger, decreased 18%, same sleep pattern. Children 6 to 9 years of old, children 6 to 9 years old with less than 10 hours sleep were 1.5 to 2.5 times more likely to be obese. 50 research studies have proven this. Increased risk of type 2 diabetes. Now, if I can comment on that one about the obese children, that's true. I'm sure that is true. I guess I get the skinny ones in my office that I'm looking at, children that are literally, they're skinny and they still have issues with grinding, teeth grinding, and with snoring. Increased risk of type 2 diabetes. Effect of the immune system results in less resistance to infections, illnesses, and allergies. These are all studies that have been done over the years. Sleep disordered breathing and ADD, ADHD. Now, this is not to say that ADHD is the same as, that sleep disordered breathing and ADD and ADHD are the same, but sleep disordered breathing mimics ADD symptoms. And this was a study done by Dr. Bonnick in 2012. There was 13,000 plus participants. Sleep disordered breathing increases the risk of ADD, ADHD by at least 50% by her study. ADD and ADHD patients have little or no REM sleep, but have delta sleep. That's that deeper sleep that that we all know about. Patients without ADD or ADHD have primarily REM sleep and delta sleep. ADHD is present in 25.2% of cases. And this is from the previous study from Stevens and Bergerson that had 501 kids that they evaluated. The long-term effects of SDB and sleep deprivation in regards to ADD and ADHD, 50% are held back 1 grade. 30% are held back 2 grades. Now, how many grades do you have to hold these kids back before they get better? Anyone have an answer to that? And I think we all know the answer to that. It doesn't happen. So this is a problem. It's an epidemic that needs to be addressed. Sleep disordered breathing and bedwetting. The reduced oxygen probably interferes with normal sleep deprivation. Oh, I didn't want to do that. Let's see. Okay. Reduced oxygen probably interferes with the normal sleep, the sleep deprivation that eliminates or reduces REM sleep, which affects brain function and disturbs endocrine and immune systems. Results in bladder dysfunction, weight gain, insulin production growth, increased infections, allergy, asthma, eczema, morning headaches, and teeth grinding. Now, all I can tell you is this. When someone is sleeping at night and they have this sleep disruptive breathing and they're getting up quite a bit during the night, and I see this with children because I do ask the questions now, and I do see the results of them not doing these things when they're wearing these appliances, getting the proper tongue posture, jaw position, airway, and of course their teeth come in straight. These symptoms go away. They just go away. Now, allergies, you're probably thinking, come on, doc, are you kidding? I had someone from Sebastopol not too long ago that came to me because I use these removable appliances with her child. And she said, I don't want braces and I don't want, the conventional orthodontic treatment. Can you do something with these removable appliances, the HealthyStart system that she heard about? And I said, sure. She'd have to wear this thing at night, and she'd have to wear this appliance 1 or 2 hours during the day. And she says, oh man, I don't know if my daughter can do that because she has severe milk allergies. And I said, well, I'll bet if you can get her to have the ability to wear this thing at night, and she tries it for a few nights, and she wears this during the day, that those allergies will be reduced or eliminated. Mother was skeptical. Mother still went for it. She came to me in less than 3 months since she lived so far away, and she said, you know what? You were right. The allergies are completely gone. Of course, the teeth are lining up as well, and the jaw position looks much better as well, but that child is now sleeping at night, breathing through her nose, no allergy symptoms, no medications, and her mother also had a younger daughter in tow that said that she is just like her sister. Can you help her out? So yes, it does help allergies. I can't say it's going to help everyone, but I do know it's going to help the symptoms significantly because they are breathing through their nose. Habit correctors. I showed you a picture of a habit corrector on the screen earlier, but let's talk about the system in general. Over 3,500,000 cases have been used to date and they've been used with this HealthyStart appliances. The appliances are a class 2 device. It's FDA approved, no latex, no plasticizers. All appliances are BPA free, and there's no silicone. So this has been around for a while. These things are so well made and designed that you can actually put these things in your body without having an adverse effect. You can leave them probably in your body for a period of time. So this is all very high quality material that is utilized in the HealthyStart system. There are different types of appliances used for different situations, and we're going to briefly go through this. I'm going to try to get this thing in another area here. Here we go. The toddler age, the one that I just showed you on the screen, and you can see it on the top. You probably can't see it as well. Let me see if I can show it to you here. Okay. There are little prongs in these appliances, and difficult to see, but those little prongs are designed to attract the tongue. You know that if something's in your mouth that's kind of feels a little funny or just a little different, your tongue's always attracted to go there. This is the same system. It's amazing how these things work. But they are designed specifically to get the tongue in the right posture and position when the child puts this in their mouth. That's the toddler HealthyStart toddler habit corrector. These are used, of course, for any kind of habits: finger, digits, sucking, tongue thrusting, cross bites, retrusive mandibles, and on and on. The next one here we have the habit correctors for children that are ages 4 to 7. Oh, I'm going to go back here again. My apologies. Here we go. Okay, and so there's different series of appliances for ages 4 to 7 with kids. And then, of course, there's the conventional systems that have been around for 50 years, literally, with the C and G and N series of appliances that all have the same quality materials used, and they all have the same ability to get the appropriate jaw posture, the appropriate tongue position, and guiding teeth in straight as the child develops, grows and develops. The arch form is also very critical in the size of the arch form. These are designed to get an optimal jaw position and size from front to back and sides, okay? It's just a wonderful, wonderful appliance. And then, of course, the occlusion of the teeth come into the appropriate position where the top teeth just barely cover the lower teeth, what we call in dentistry a class 1 occlusion. The HealthyStart corrects tongue thrusting, abnormal swallow patterns, mouth breathing, abnormal lower resting tongue position. And remember, I told you to check to see if there's a frenum that's causing that tongue to lay low in the lower jaw. Thumb and finger sucking, open bites, overjets and flared incisors, speech problems, lisping. Of course, if the teeth are malpositioned, you're going to have speech problems. Mandibular underdevelopment and a narrow palate. Normal tongue posture. The tongue is elevated to the roof of the mouth. The tongue tip is behind the rugae, or those little ridges that are on the roof of the mouth. The teeth are parted with about 3 to 4 millimeters of freeway space from the top teeth to the bottom teeth. There's a slight spread of the tongue interocclusally. Promotes nasal breathing, and the lips are closed. The abnormal tongue resting posture is the tongue is within the lower arch. It just lays down low. If you've seen kids that have Down syndrome, they typically have a low tongue posture, and you'll usually see that those children develop with a deficient maxilla and a prognathic mandible, and that's all because that tongue posture is in the wrong position. So that's a very demonstrative type of situation where that tongue is low in the arch. The tongue tip is forward between the incisors. That's what we call a tongue thrust. That's where a child's top and bottom teeth don't match together properly, so the tongue acts as an obturator when the child swallows. They're doing this thing hundreds and thousands of times, right? Bad habits. We're trying to establish good habits, and that's what these appliances are going to do immediately. You'll see the lips are parted, and you'll see their front teeth kind of hanging out. Often these children are mouth breathers, and they have many times they have this thing called an open bite. Now, this is a great way to follow or to take a look at a child and see how their swallow pattern habits are. Give them a glass of water and observe what happens when they drink water, okay? When they're swallowing, they close their upper and lower teeth together. The tongue is elevated in the palate above the shelf. The tongue tip is in back of the prongs. That's with the appliance in, of course. And they don't move their lips, and they practice in front of the mirror when they're doing this, right? All of the above should be practiced even when the appliances are not in the mouth. And then parents are asked to keep a chart of the wear time that the child has. So they have a little score sheet, and they indicate how often they're wearing the appliance per the doctor's directions. Now keep this in mind. This thing takes some time, and it does involve parental observance, so that they have to be intimately involved with this. If you expect a child to do this all by themselves, it's not going to happen, or it's not going to happen as frequently as you'd like. Parents have to be intimately involved with this thing, and it's a really great opportunity for parents to start to understand what their child is doing inappropriately or that they're not doing effectively, and to watch how nicely they adapt and they get into a healthy swallow pattern. Parents will come in literally within a few weeks after wearing these appliances, and if they're doing a halfway good job with it, they'll usually come in with a smile on their face and say, you know, doc, this has really changed our lives, period. The rate of swallowing, this is very interesting. We've all heard of myofunctional therapists and what they can do, and they do an awesome job with these children. However, the children get the results from the time that they do their exercises or their swallow pattern exercises that they have to do throughout the day. Okay, so the rates of swallowing, this is a really good thing to look at here. 2 times per minute during the day that they swallow, that kids swallow 16 hours a daytime, you get 1,920 swallows. 1 time per minute during sleep, during 8 hours of sleeping, you get 480 swallows. Total swallows, 2,400. Using the habit corrector, 2 hours during the day, you get 240 swallows. 8 hours of sleeping, you get 480 swallows. Total swallows, 720. That's proper swallowing. Typical myofunctional therapy swallows per day is 200. 28% of the habit corrector. So this is a continual habit thing, that a good habit pattern that these children establish very quickly, and that's why we see the results as fast as we do. Symptoms to look for an anterior open bite. This basically just shows that their posterior occlusion is intact. The teeth are touching in the back, but in front, that tongue is sticking forward between the teeth, or their thumb is in their mouth, or what have you. Typically, we see the upper jaw is narrow, so that this is not a picture of that where they'd have a narrow palate, but you can see that those teeth are kind of pushed in towards the tongue. Symptoms to look for tongue thrust swallow patterns. You can see where the tongue is going here, and you can see where the teeth are going. When we have excessive overjet with minimal overbite. Overjet is the amount of the front teeth sticking out in front of the lower teeth. They're jetting forward from the lower teeth. Typically that happens because the lower jaw is retruded. And when they have a minimal overbite, that means the top teeth covering the lower teeth a little bit. Most people come in and they see a child that has an excessive overjet and they say, oh man, this kid's got a terrible overbite. Not the overbite, it's an overjet. Overjet is when the top teeth jet forward. Overbite is when the top teeth cover the lower teeth excessively. Flared upper incisors, this is a very common one that we see as well. And you see the lower teeth are telescoping up into the palate. Thumb or finger sucking, this is an obvious one or two. You can see where that digit is going, where that thumb or finger is going between their teeth. Bad habits. Constricted maxillary arch, this is very good. This is where it shows the upper arch is constricted. Okay, it's narrow. And so we have just a few anterior teeth. We have 4 permanent anterior teeth, and they are really crowded. And on below, they are not as crowded. And then, of course, you have 12 baby teeth left and first molars that are tucked way, way back there. They're going to be very crowded. And if we don't do something, we don't have some sort of intervention, they are destined to go through a lot of fixed appliances with orthodontics in order to get this thing corrected. These are easily corrected with the HealthyStart system. Okay, the symptoms to look for a mandible displaces to one side, showing a crossbite. This is that reverse swallow pattern that I told you about earlier. Okay, and you also see the lower midline, where my cursor is here, is off to the right side, okay? It's the left side of on the slide here. But that child is, occlusion is such that the lower jaw is shifted over to the, in this situation, over to the right side, and the upper jaw is constricted. Okay, and this causes this reverse swallow pattern problem. Now, by the way, if a child stays like this for a long period of time during their growth and development years, that's going to stay like that forever. If they quit growing, you're done. The only way this gets corrected is with a surgical expansion appliance, the same expansion, the RPE that you saw earlier, but in an adult, they would have to have surgical intervention, which is like a modified Lefort 1 procedure. Pretty invasive. corrected this kind of thing very nicely with the HealthyStart system. Symptoms to look for lingually inclined lower incisors. This is where you'd see the lower lip would roll under the upper anterior teeth, and you can kind of see with these kids, they would have a tendency to have their lips apart and their front teeth showing. If there's a large freeway space, we call this a lateral tongue thrust. So remember, the tongue acts like an obturator, and in this situation, that tongue is laying out on the sides of the teeth and the posterior segments of the teeth, creating an open bite in that area. Okay, that's where the tongue goes. That's where those teeth are going to go as well. And then on the right screen, it says this is an extreme overbite or deep bite, where the lower teeth are telescoping up into the roof of the mouth, and the top teeth just completely hang over the lower teeth. When they are in occlusion, when they're biting on their back teeth, you can't even see their lower teeth. Various other problems causing malocclusion: a rolled lower lip. This is where you would, typically when you see this child, you would expect the upper teeth to be flared forward and the lower lip is kind of running up between the upper and lower teeth. Various other problems causing malocclusions is this rolled lower lip. This is what happens with treatment. Okay, so the left screen shows a female, 11 years, 6 months, excessive overbite, excessive overjet after 11 months of treatment. Take a look at the overbite and overjet, getting much, much better. And then, of course, after 53 months, let's take a look at that here. Let me back up again. I'm sorry. Previous. Okay. I got to move this thing out of the way. I don't know if this is interfering in your screen or not, but you can see an ideal class 1 occlusion that's developing very nicely from the middle slide to the one on the right. This is ideally what you want to have with every child, every adolescent. This is what you expect to see with their adult dentition, coming into a nice overbite and overjet relationship. If you want specific numbers, an ideal overjet and overbite should be about 1 to 2 millimeters. From measuring from the lower incisor edge to, or lower incisor to the upper incisor, the facial surfaces in overjet. And then, of course, overbite is the top teeth covering the lower teeth, 1 to 2 millimeters. These are going to show children that have some issues with breathing, of course. And this is a child that we're looking at 10 years of age on the left screen. And then the resulting situation at 14.5 years of age. Keep in mind that this is just a picture of a child that's about 4 years later. The change that that child made from age 10 to 14 did not take that child 4 years to get there. Not with this appliance therapy. It's much faster. But however, it just kind of gives you an idea of you know, the way that child's going to continue to develop in that corrected fashion. Take a look at the airway when the child started at age 10 compared to the airway that we have between those little arrows. This is the before. That's relatively narrow. This is on a lateral cephalogram. And then this is at 14.5 years of age. So this is about 10 millimeters here. And I'm assuming this is probably about 3 millimeters is what's indicated here. Case studies. Look at the facial balance of this 5-year-old here. We would immediately look at the nose, the upper lip, lower lip, and chin. I mean, this is what I do as an orthodontist, and what I assess these children when I look at them before they even sit in the chair. I'm looking at their posture, their head posture. I'm also looking at the balance of their head tip to the right or to the left. The facial balance is the most critical thing. I look at facial drape first before I get a look in the mouth and the teeth. And then you can see the changes that the HealthyStart system made with this child wearing an appliance at night and maybe an hour during the day. So from 5 to 7, you see a complete, beautiful facial balance of the nose, upper lip, lower lip, and chin. This is routine. It happens all the time. I can show you cases daily in my practice where this has occurred. We take tons and tons of photographs and x-rays to show this, to demonstrate this kind of thing. On the top picture, the 5-year-old has all primary teeth that you see there, except the lower teeth are starting to come in, and you can see there's a missing one on that top slide. And then, of course, the lower anterior teeth are coming in, and the upper front anterior teeth are coming in, and they're coming into a much nicer position at age 7, and then post-retention 13 years of age. Now, this child is not going to be actively seen every single month or two in this office, nor in my office. Typically, when we get the results that we want, and my goal is to get the upper and lower anterior teeth coupled together in good function and good overbite-overjet relationship. Then I see them every 6 months to a year. They're wearing this appliance at night, every other night, every third night. It's, you know, it really depends on their dentition development. And I'll give them those instructions, and I'll see them on a recall level just to see how they're doing. In a dental office, a general dentist that's doing this kind of thing, or a pediatric dentist, they would see these children at their recall appointments to have their cleanings and such, and they would also observe the appliance wear and measure overbite and overjet and look at the dental development of these children. Very easy to do, very fast, and highly effective. This child here is from 8 years of age to 14 years of age. The smiling pictures, look at the gummy smile of the 8-year-old. The gap between the top front teeth, the excessive overjet and overbite. That child's lower teeth are hitting the palate, probably the nasopalatine papillae, okay? And that child is gonna have a difficult time chewing and swallowing with that kind of dentition. Okay, they will, and they do, but they're compromised. So look what happens from 8 years of age to 9 years of age, and look at the difference of that occlusion. No braces. We have an orthopedic correction of the mandible and maxilla, and we also have an orthodontic correction of the teeth. Routine. This child over here, let me give you a quick story on this one. Mom had braces and jaw surgery. Mom had a retrusive mandible. She probably had some issues with snoring. I don't know the specifics because this was a long time ago. But she said, look, I really appreciate what you did, Doc, but, you know, I have a little girl that looks just like me. Is there anything you can do with her? Well, this is her little girl. She's 5 or 6 years of age. She just shed an upper baby tooth, and a new one's coming in, and she has 2 lower anterior teeth that are erupted. Those lower teeth are telescoping up into the roof of the mouth. She has an excessive overjet. If you look at her profile picture over here, you can see that the nose, upper lip, the lower lip is tucked back. She's got an incredible chin, but the whole jaw is set back. So watch what happens here in a relatively short period of time. Here's her profile now. This is her bite. This is the way her profile is all the time. She's not posturing her jaw forward. This is her smile line. This is her profile. Take a look at the nose, upper lip, lower lip, and chin. Look at the alignment of the upper and lower anterior teeth. She's wearing this appliance primarily at night, and she's doing maybe an hour during the day. That's it, okay? And these teeth are coming in like this. This is her a little later, okay? She's probably maybe teen, preteen. Most of her adult teeth are in the mouth. And I think this is graduation time from high school, okay? She's not wearing the appliance a whole lot, but look at what's been maintained. It's beautiful. Profile has been maintained. So once the profile is corrected, once the orthopedic change happens, that appliance continues to work with their growth and development to advantage. And there is no way that that's going to ever go back, ever. And this is her. I think she's going to college now. She's sporting her grandma's bandana that she made for her. She also had her wisdom teeth out. She hasn't worn her appliance forever. She comes back to me and she says, hey, Doc, can you get me that appliance? I can't even remember the name of it, but I know it did me so good. And you can see that lower front tooth moved a little bit, but lo and behold, if she wears that appliance an hour a day, plus wear it at night, that will be lined up. I'm waiting for her to return from me to come see me after college or at break at some point so I can get some more pictures and I can give you the update on her. Now this shows the profile changes of the same child on the top 2 slides before when she was about 5 or 6 years of age, and now she's about 21 on the right. This is her mother, okay, on the bottom slides before, and then she had braces and jaw surgery to get that kind of a result. Now it looks fairly strong in her profile. Just looking at her profile, we know that she's got a good strong chin, but just like her daughter, that jaw is recessed. It's retrusive. She's got an excessive overbite and overjet. We changed all that. Now, this child did not have any surgery. She didn't have any braces. She just wore this appliance at night and maybe a little bit during the day for a while. And I would see her on recall every 6 months, a year, whatever, just to kind of, you know, she was still in town. I'd like to see how she progressed. And lo and behold, we got a series of beautiful photographs on this young lady to show the stability of the results that we attained with the HealthyStart Smith system. I don't think anyone would want to choose jaw surgery and braces over a soft, pliable appliance that they would wear comfortably at night and maybe an hour during the day. But this is exactly what the mother was looking for and hoping that there was another avenue for her daughter, and there was. This shows profile changes of a young man from ages 9 years, 11 months to 25 years, 8 months. Kind of nice. Here's another one. Look at the excessive overjet in the 12-year-old. And then look, now he's smiling with his profile picture here, but you can see those front teeth are really kind of sticking out. And then at 15, the top and bottom teeth are more in proper position. And then look at the malocclusion that you have in the upper jaw of the 13-year-old. And then at 15, no braces. Now, this doesn't require a tremendous amount of work. We're using the natural growth and development and eruption of the adult permanent teeth that are growing in. We're also using the appliance that is being worn to put some pressure on those upper and lower anterior teeth to align them and get them in proper position and alignment. You can see the difference of the lower anterior teeth that are crowded. There are still several baby teeth on the left screen. And you can see the change with no baby teeth left on the right screen. Those are all adult teeth now. 12 months of HealthyStart. That's when these pictures were taken, 12 months apart. I can assure you that these changes were occurring throughout this entire 12-month time frame. Of course, you have more permanent teeth coming in, and the canines that are erupting in straight, using their natural eruptive forces to guide those teeth in straight. The website is thehealthystart.com. The phone number is 844-KID-HEALTHY. And if you want to email, info@thehealthystart.com. There's also these cool little brochures that HealthyStart has provided. You can see them right here. These are great. I pass these out frequently. I pass these things out like all day long. Okay? All right, Kathie, thank you. Thank you all for listening. Kathie's going to take it from here.
And I'll tell you that as a parent and a grandparent, that I've got some takeaways that I'm sure others would agree with. You simply want to start early. This is a comprehensive treatment. And just like when we help our kids with our homework, be compliant, because it's a permanent solution, and all the pictures and all the data show that it's irrefutable. So I would be telling other moms. Hopefully from your end, the takeaway is that you want to join us, because everybody wants to be a part of something bigger than themselves. And the people that we have on this program tonight, all the different disciplines and specialties, well, you help make up the dream team. And because you are on with us tonight, I do want to share a couple of things, how to get your CE credits. What we have is an opportunity. You can go to thehealthystart.com. You can call 844-KID-HEALTHY, and you will be able to talk to anybody there about registering, taking care of your CE credits. If you wanted to get this lecture, this training, you've got several options. One of them is you can do it online. Another is that you could go to a live presentation. There's one going on at the end of July in Austin, Texas, and then again in Dallas. We've got them almost every weekend at a different point around the country. You can go to thehealthystart.com, go to events and providers, and you can register for the one that's convenient for you. As I've just been describing, we're really excited about the fact that we have got a big deal happening on August 4th and 5th, and that is going to be the celebration of Dr. Bergerson's 50 years in practice, where he's affected so much of the world in child health care. And the $3,400, this one event only, is $1,700. Now, if you choose to do this online, that's great. And by the way, we want you to bring your staff. We want you to bring the front office and the assistant and the hygienist. And
very important.
But for even those wanting to do it online or to do it at another lecture, we would offer you $500, again, because you were with us this evening. Now, I'm going to ask a couple of our doctors to answer a couple of the questions that have come in tonight. And let me start with Dr. Jill Ombrello. Jill is a remarkable presenter for us. And I'm not overstating that when I say it. She's a 4th-generation dentist, and she is the product of the product. She, as a child, had her father introduced early to this whole Orthotain company, so she wore the appliances. And she has a practice there for many years, Central Dentist in Dallas. And what we want to ask you about, and I guess with all the sleep doctors and the people that are starting to get into the younger and younger set, are asking this question: do children have to be diagnosed with sleep apnea in order to receive the HealthyStart treatment? Dr. Jill Ombrello? Welcome.
Yes, great question. Thank you so much. Thank you, Dr. Marino. That was a great presentation. I really enjoyed everything you spoke about. Kathie, I think to speak to your question directly, it's a very common question. In order for a child to be diagnosed with sleep apnea, they need to have an in-hospital sleep test, which can be rather costly. In my area, it can cost upwards of $2,500 to have that sleep test. Some of the children won't have that sleep test ordered because their outward signs and symptoms aren't as severe for sleep apnea or obstructive sleep apnea at a young age. So the questionnaire that Dr. Marino mentioned several times is a great screening tool that I use in my office and have every parent fill out on their child between the ages of 2 and 18, really, but really focusing on those 2 to 12-year-olds. They don't have to have a diagnosis of sleep apnea, but if they have these outward signs and symptoms, like Dr. Marino explained, like the mouth breathing, thumb sucking, anterior tongue thrust, snoring, dark circles under their eyes, signs and symptoms of sleep disorder breathing, those are all outward signs and symptoms that we can treat very effectively with HealthyStart.
So the number of children that you have taken care of, how many of them have even had a sleep test or are even familiar with the term of sleep apnea as the parent, and how do you guide them in the very first steps?
I'll tell you, when I first started, none of them. When I first started this conversation in my office years ago, parents kind of thought I was crazy. I was asking if their children sleep with their mouth open, if they wet the bed, if they suck their thumbs, and parents just thought I was kind of nosy. And when I explained the bigger picture of how all this can affect their overall growth and development, the conversation began, and they were more forthcoming with what was actually going on with their children. And they were more willing to actually observe their children at night while they were sleeping. I had parents start taking videos of their kids sleeping at night and texting them to me so we could evaluate it together. As I have formed more of a network of people, of doctors that I work with, chiropractors, physical therapists, board certified sleep doctors, pediatricians, etc. Now I start to get some children who've had diagnosed sleep apnea, and they're coming to me because they're CPAP failures. These little kiddos are unable to wear the traditional CPAP that's strapped onto their face and around, and they're really looking for a solution. And so it's been great that these pediatricians and board certified sleep doctors are looking to make this referral as a HealthyStart provider, because they know that this is such a great option for these kids.
Yeah.
Well, when you describe that, the image is just heartbreaking, and it brings me back to how many times have I heard you say, the parents who want more for their children, want better for them, because maybe they know what they're destined to become if they don't intervene this early.
Absolutely, Kathie. I'm out here in San Diego, super excited to start another certification was so chatty and talked about how she doesn't sleep well and she was snoring on the plane, and was talking about her grandkids. And long story short, it was a very long story from this lady, but I'll shorten it for you all. Was telling me about two of her grandkids. One who was really, really struggling. He was struggling in school, struggling with ADD, ADHD. His mother didn't want to medicate him. It sounds like he had so many of these outward signs and symptoms of sleep disordered breathing. Then she talked about her granddaughter, who was sweet and kind and had, so many friends at school and wasn't necessarily struggling, but definitely had some outward signs and symptoms of sleep disordered breathing as a 9-year-old bedwetter and thumbsucker and mouth breather. So when I talked to her about HealthyStart, she was really looking to have some sort of resource for her daughter to look into for her grandkids. So there are the children present in many different ways, from the very struggling child who's struggling in school and concentrating and acting out, to the sweet kid who is unlock the potential of that little kid, and they do so much better.
Thank you, Jill. I appreciate it. And I know when you started out early years ago, and it's like such a strange, obscure subject, and now we find how many children are impacted by this. I'm going to move over to Dr. Amanda Wilson, who's an orthodontist that comes in and works with us all over the country from Hawaii. And there you are. Hey, Dr. Wilson, so happy to have you with us. We just have the greatest doctors. What a panel lineup. Every one of them stellar. And I love the fact that Jill started out as a child wearing this appliance, and all of our children, or in my case, grandchildren, have been benefited and blessed by what this appliance has done, which means that we come to this with such a heart because we know what we're doing for these children. So Dr. Wilson, my question to you is, this is, as I am told, comprehensive treatment. So if there can you tell me any other treatment that can accomplish all these things simultaneously? And when do you actually start to talk to a parent about this? When do you engage in that conversation when you're taking care of that child from the first time they go to the dentist? Dr. Wilson.
Yes, thank you so much, Kathie, for asking that question. It's a very complicated question, but I'm going to give you a simple answer to start, and that is early is the answer. But first, I want to say thank you to Dr. Marino and to Jill for weighing in today and for a great presentation before I address the rest of this question. So I want to address all the dentists out there and give you a little bit of feedback about when to start and about the comprehensive aspect of this program and of this system. But first, I want to address you all actually separately. So when I mention your specialty, please listen. And if I'm not talking about your specialty, you're welcome to cover your ears or listen on. But first, I want to talk to the orthodontists out there, okay? Orthos. First of all, a couple of things I want to say to you about this system and why I want you to get on board. Number one, skeletal age versus dental age. We know it's different. We know it's changing. We don't know why. Is it environmental? Is it the chicken? Is it the milk? I'm not sure. But I'm a mom to school-age children. I have an 8-year-old and an 11-year-old. And I know skeletal age versus dental age is changing. Some kids are reaching their skeletal maturity, peak maturity at age 8. Some girls, sometimes 7. Sometimes their dental age is way off from that. Therefore, sometimes we need to treat patients in 2 different phases. More than ever we need to. We need to address the skeletal aspects early while they're still growing. Once they finish their maturity, they've had their puberty, their peak puberty is over, you cannot address the growth aspects or change the orthodontic aspects of the bite effectively. So you need to address them early. That's why I think this system is fantastic. Number 2, let me tell you a little bit about how my typical, exams often go. What do patients want? So typical patient will say, this is my patient, okay? So I say, hey, what are you doing here today? And they say, oh, hey, I'm here for a retainer, okay? And then they say, oh, can I just wear it at night? Okay. Can I have Invisalign? Okay. Can I have something clear? Okay. I don't want anything bonded to my teeth. All right. Those are the 5 things that patients want. But guess what? All this, before I would say, that doesn't exist. That's impossible. We do braces, we do Invisalign, we might do an appliance, an expander. Everything has something bonded to your teeth. Now and it's been out for dozens of years already. It's already treated 3.5 million cases through HealthyStart. It's a removable, nighttime only appliance. It's exactly what patients want. It's an incredible patient experience. So beyond that, orthodontists, let me tell you one more thing. I'm going to give you a magical date, 1999. You all may know what happened in 1999. Invisalign launched to orthodontists, right? It changed that whole nature of orthodontics. Everything changed after that, right? So what did we do? We fought against it. We pushed back. We did not embrace the change that occurred. And what happened? The GPs took all the cases because we didn't embrace it. Don't do this again. If you want to save your profession, don't complain to me that the GPs are taking your cases. You can jump on board new technology. This is the technology for the decade. This is the technology for your generation. The early adopters will do amazing things in their community and will profit. So jump on board. Lastly, you say, I don't see kids age 2 to 6. Well, why not? Look around in your waiting room. I'll bet you, okay, now it's late, especially those on the East Coast, but I bet those of you who tomorrow, you're probably not working, it's Friday. Next week, Monday, go look in your waiting room. Go look around. I'll bet you have 6 to 7 kids in the 2 to 6 age range just sitting in your waiting room. What are they doing there? They're playing with blocks, they're reading books, they're watching your movie, playing with your great video game system. Do an exam. Examine them. They're siblings of your patients. They're the kids of your patients. They're out there. Invite them in. Take a look. Let them know what you have to offer. So thank you, orthodontists, for listening. All right, now you can see I love my orthos. We're going to talk about pedos. Okay, pedos. I have a couple things to say to you. First of all, you have those patients in your waiting room. Why not start examining them? You don't even have to market to them. Number 2, pedos. I know you're doing phase 1 out there. I know you're doing habits. I know you're doing basic orthodontic changes. I know you're doing expanders, but why not have an incredible patient experience? Why not expand them comfortably? Why are you doing all these quad helixes and bonded, fixed appliances that are uncomfortable, that potentially obstruct the airway? Why not do something nighttime, comfortable, and gentle and patient-friendly? So, and why are you waiting for the 6s to erupt? Why not start earlier when patients are compliant and happy and excited to start? So thank you, pedos, for listening. And lastly, of course, I come to GPs. GPs, you get it all, right? The world is your oyster. You can do anything. You can do everything. The patients are out there. You do sleep. You do ortho. Why not do it? You say you don't see pedo patients? Why not? Pedo patients are the lifeblood of your new practice, right? The future of your practice. Start seeing pedo patients. You say you don't like kids? Let me address that barrier. Why not? If you don't really like them, act like you do, right? Act like you do, or find an assistant who loves them and have fun with it, because kids are fun. Enjoy it. Be healthy, have fun, and that's what HealthyStart is all about. Hopefully I answered your question.
Amanda, what amazes me is that as a parent or grandparent, I see it in such a simple way. If a child walks through your door, you have to be able to take care of them. And it doesn't matter to me if the person who solves the problem in my house is a GP or a highly specialized person. I need the help. And if I understand this is available and it's withheld, I am going to spend the rest of my life being very unhappy about that. So I am so thrilled that this has become so much a conversation. And with the advent of social media and the digital world, we're able to reach more people like we are right now. So Dr. Wilson, when is the next, you're in San Diego, tell me what your lineup is for lectures and training, and how do you compare this for all the teaching and the consulting you do to any other treatment that you walk into a dental office to talk about?
Absolutely. Well, right now, yes, I'm in San Diego with Jill, and I'm so excited to have some dinner with her shortly. If you look outside, there's some amazing boats out there. I don't think you can see it, but we have a great time at the HealthyStart lectures. It's fantastic. It's collaborative. It's fun. You will go into these lectures and you will meet all sorts of amazing proactive people and learn, and you will sit through 16 hours of incredible lectures, and as well as direct patient screening. You're going to learn to work directly with patients, how to screen patients. There will be prospective patients there that will be screening and learning how to use and the tools that you're learning. So definitely the next place where I'm going to be, and then I think our next lecture, maybe not before, but the next one I'm going to be at is going to be in Austin, end of July. I hope to see you all there. It's going to be really fun. It's going to be in the Texas Hill Country. But you know, there's tons of lectures through HealthyStart. They're all really fun. They're all very collaborative. Please take a look at our lineup on the website, thehealthystart.com.
Thank you, Dr. Wilson. That's great for me to now segue into asking Dr. Marino, who does such a phenomenal job on a webinar at the end of a long day and a long week at both of your practices out there in Vacaville and Fairfield, California. So my question for you is this. You have spent 30 years doing this. You've known about this for 30 years. The people who are going to these lectures like we've just been talking about, or getting a little exposure in an opportunity like this webinar, what do you say to them about, okay, we can't change yesterday, but what does the future look like for them, for their practice and their patients?
Well, this is a game changer. This is something that's really different, even though it's been around for 50 years. But the medical and the dental profession, this seminar that we're listening to, that we're all listening to this evening, we have medical and dental professionals that are on this this webinar. This is a rare situation to occur. We've done one of these recently in a local hotel. We invited 35 people to attend, 50 showed up. So we know that there's an interest. We had nurses, physicians, pediatricians, pediatric dentists, assistants, RDAs, hygienists. We had quite a mix of individuals. And we also had a sleep medicine specialist that was speaking, as well as myself, so that we had a good perspective of what sleep disordered breathing is, how it compares to sleep apnea, what are the differences, and what do we look for. So in short, we know that there's a need. There's a huge need for this. We can help these children. We need to have mom and dad involved with this if we want to be successful with it. In most dental offices, we just see a ton of little children. I've been doing this a long time, so I am known for this in my area. Now, I can tell you from many years ago of doing this type of therapy and this type of treatment with children, I was a big advocate of early treatment right from the get-go. I was trained with this at Ohio State University. My chairman actually could not introduce this system 30 years ago in the in the orthodontist residency program. It was just, there wasn't enough room or time. So he invited us 6 residents out to his private office, and he said, let me show you where the future of orthodontics is going. He knew about this 30 years ago. He was involved with Dr. Bergerson at Northwest University, and he said, this is going to be the future of orthodontics right here. It's not only the future of orthodontics, it's the future of dentistry in general, and medical people need to get on board to understand that we have a solution to many of their problems and concerns that they have with children. The important thing is right now is that the medical community needs to ask the right questions. The pediatricians that are out there listening, you need to ask the questions to the parents. I can't tell you how often a mother or father would tell me, my kid snores terribly, and my child's pediatrician never even addressed that. Ear, nose, and throat doctors tell me often enough, and this is no offense to the pediatricians, I'm not beating you up here or anything like that, but they said that they're not sending these patients early enough for potential tonsils and adenoidectomies. Now, what do you do with the children that don't have problems with tonsils and adenoids and snore and grind their teeth and have sleep disruptive breathing? They may not be apneic, but what do you do with them? You can't tell them, well, maybe you'll grow out of it. It just doesn't work anymore. Parents are looking. I get nurses that come to me with their children. They've looked for a long period of time, and they said, where have you been? How come no one knows about this? Well, people do know about it. But unfortunately, we need an army of health professional people, of dentists, of different specialties that are interested in doing this kind of thing and implementing it. The heavy lifting has already been done. Dr. Bergerson did all the heavy work with these appliances many, many years ago. He had the vision. He knew what this thing was going to be all about. And obviously he's done very, very nicely with it. He still lectures and goes around the world talking about these systems. And he's got the best of the best of the best available to us to share with our patients.
Okay, I've got a question, maybe almost 2 of them. You have known him for 30 years. So he took a lot of, what do they say, sling and arrows. He had to defend against a new idea, regardless of how much better it was, how much of the heavy lifting has he done for us? And in your, not estimation, but total awareness, is there anything that you could compare to this treatment?
You know, over the years, I attend the seminars, the national, international conventions and such, and I see what's out there. And I've looked at things for so many years. Now, please understand, I have no vested interest in this company. They're not paying me. I'm doing this on my own because I have a passion and a love for what I do. There is nothing that touches these appliances. There's nothing that touches them. Dr. Bergerson has developed a system, and he had the vision to understand head and neck anatomy and how it applies to a child, a growing child, and what to do to get that tongue in the proper orientation and the jaw in the proper orientation. And we're not talking only about front to back. We're talking sides too. So we want to make sure that we have the width of the arch, and we want to have the anterior posterior positioning, appropriate position of the jaw as the child grows. The growth and development studies that we demonstrated earlier are indicative of this downward and forward growth. We all know this. All dentists know this. We all are very well versed from our training as to what is needed to get an appropriate function and aesthetics of a child's facial and skeletal development. He's just put it in place, and he started 50 years ago with this. Amazing man.
Amazing man. And you'll be with us in August, and we're so looking forward to that. I am hoping that people will take advantage of the fact that they have an opportunity to hear directly from him. I think that it's something that they will look back over their career and say, the man who developed this, here, he's in the picture with me. I actually learned from him directly. You know, this is something I will tell you, that this is at Northwestern at the law school. They have at the law school an entrepreneurial program, and Pittsburgh Law School is the name of it. He actually spoke on a podcast in the last week or two about the fact that we know now that a child's brain starts to develop as well as their intelligence and capabilities before they're born and up to age 5. Now, knowing that, Dr. Marino, is there anything that you would say that would make you hold back on giving your child the best REM sleep and brain function and airway, even at these very early ages that we're talking about?
Well, you know, I don't know all the medical literature that's out there. Most of you people that are in medicine out there that are listening know it probably much more than I do, but we have an answer to a significant problem that needs to be addressed. And there are so many children that need this kind of help. And when you start talking about this in the office, anywhere, you're going to get a response. People, just like Dr. Ombrello had indicated, she was on a flight and she had a lady that was just talking about this very thing. It's something that is valued, and parents are looking for this, and physicians need to get on board to be aware that this is available for their patients. And certainly sleep medicine specialists that know that we have an answer for these children that they don't maybe have an answer for, and that maybe that CPAP device may not be the appropriate thing for that child at this point in time. Why in the world would you want to let a child grow inadequately when you can give them something far better, far superior, and much more gentle and non-invasive to give them the best sleeping pattern that they can possibly have and the best profile that they can have simultaneously?
And my last question or point, Dr. Marino, if you give them all the best, the best, the best, the best, is it going to cost them more?
This is fabulous, and I'm glad you asked that question. I'm surprised we didn't get anybody asking about money about this. That's usually a common one that comes across here. But put it this way, this type of treatment modality over the period of time that we're talking about is very cost effective, even if there's no medical or dental insurance involved. Very cost effective. And what they're supplying for that child is, you know, you can't put a number on it. You really can't.
If you go to the HealthyStart.com, you'll be able to look and see the events and see all of the lectures. And we encourage you to get registered for any one of these lectures online or at a location, most especially the celebration that we have coming up in Chicago on August 4th and 5th for the celebration of the life's work of Dr. Earl Bergerson. So I'd like to thank you, Tony Marino, for everything that you do for our company. And it is just like the rest of us know, we're here for the reason that we know that there's nothing bigger, no more purposeful that we could do than sharing this. And you do an excellent job. We're so proud that you work with us. So thank you, Dr. Marino.
It's been a pleasure. Thank you.
Thank you, and thank you, Dr. Jill Ombrello, and from Dallas, and from Dr. Amanda Wilson, who's here from Hawaii, and thank you to Susie Lafredo, who is driving the mechanical end and technical end of our presentation this evening. I'm Kathie Turner, and for HealthyStart, good evening again, and thank you for being with us.